Hey, welcome to another episode of Footnotes. Today we're going to be talking to Kim Smith. She's the founder and CEO of Equitable Technologies, and she's based here in Columbia, South Carolina. We cover a wide range of topics, mainly centered on women's health issues and the technologies that she's developing to help some of the health disparities and lack of equity that we find, unfortunately, in healthcare here in the United States. I learned a ton in this episode, and maybe more so than a lot of episodes that we've done, I was hearing things that I've never heard before. I think you're going to hear this too, and I hope you learned something. Thanks for listening. Well, Kim, thank you for joining us today. Of course, we're talking to you. You're Kim Smith, and you're the CEO and founder of Equitable Technologies.
Yes.
And you're based here in Columbia, is that correct?
I am.
Okay.
Right here in Columbia.
Well, thanks for sitting down with us on Footnotes. I heard you pitch your company earlier this summer, and I was just very intrigued, not only by what you're doing as a company, but sort of in terms of how you got started and kind of the why you got started. And so maybe let's for the listeners, let's just begin at the beginning. I mean, what is Equitable Technologies trying to do for people out in the marketplace?
Wonderful question. You know, Health Evolve, we are a software company that's really committed to closing the gap on health disparities. And I'm especially interested in women's health, starting in pregnancy and going to menopause. There are so many disparities. And the reason I entered into healthcare 18 years ago was because of my passion for public health and data science. I happened to go to the provider side and work in management and business development for many years. But due to my own lived experience, having survived a hypertensive disorder pregnancy 12 years ago and advocating for 11 years, this has been just a part of my life story. And I would say my purpose of really creating a way to use technology to address a very growing problem that we're having really globally, which is addressing the health disparity gap.
So when you say health disparity gap, I mean, what does that mean?
Right. Well, one key one focus area that we talk a lot about with pregnancy is, I know the Gates Foundation stated that 800 times a day, a woman dies from pregnancy. There's a global stat that says every 7 seconds. And a lot of that is linked to hypertension. In fact, a significant percentage, about 80%, happens after you deliver the baby. And for BIPOC communities, so Black, brown women, Asian, those communities, they're definitely more likely to have a fatal condition and have a loss of a mom versus other populations, other demographics. So there are definitely disparities across different populations. And in truth, 20% of that can be addressed in the room with the doctor. There's this 80% that really is addressed outside of the walls of the clinic. So when I think about disparities, I think about creating a way to really understand the health equity gaps of each individual patient or health consumer and going after that 80%. How can we use data science, use technology to help close the gap and provide a view into providers to provide a more personalized care plan. So that's really important to understand, because if we aren't disruptive with our existing care delivery model, we're not going to address the disparity issue. So if you think about it, for 18 years, of course, I've been growing the machine, growing the business of corporate medicine. But for 11 years, I was advocating with this bullhorn of improving health disparities for moms, working, serving from a volunteer perspective with the Preeclampsia Foundation on their board, then as board chair, working with the Office of Women's Health. So one side of me, I'm growing the existing health ecosystem on the provider side, being hospitals and medical groups. And the other side of me, I'm advocating for disparities. And I got to a point where I realized, okay, these aren't going to connect unless there's some disruption. Our existing health ecosystem is not designed to really address the health disparity gap how it's designed today. You have to do something a bit disruptive to help bridge the gap and connect the dots, so to speak.
So You talk about worldwide. I mean, that statistic, I think I heard you say that every 7 seconds, a woman loses her life due to either delivering a child or being pregnant. That is, I'm still trying to wrap my brain around that. And I think about, in my own life, what that could mean. But focusing back, if we sharpen the focus a little bit to just the United States, I mean, do those things happen in the United States? I mean, to me, it's easy to imagine somewhere else that is the case. But here, is that?
Oh, yes.
Okay.
Oh, yes. So about maybe 12 years ago, well, closer to 11 years ago, after my loss, because, of course, I survived HELLP syndrome. We lost our daughter, Lauren Kelly, in the process. And about 6 months after that loss, I began really trying to get involved to help other people understand the stats, right, around HELLP syndrome and preeclampsia and other hypertensive disorders of pregnancy. And I was introduced to Nina Martin, who's a reporter with ProPublica. She was writing a story on disparities across the U.S. And I was actually one of the individuals that she interviewed to share about my experience and our loss. Her publication in ProPublica went on to really help to push the USA Today article that many people reference even today around disparities. And at that time, they did know that at least for Black women, we're 3 to 4 more times likely to die from a pregnancy. And it doesn't matter your income status. It does not matter your educational background. And trying to just get our arms around that to say, okay, man, this is insane. How do you even address this in our current care delivery model? So the stats are definitely there for sure in the U.S. But the frustrating point that I had last year was realizing for 11 years I've been advocating and the stats are worse. So I was very unimpressed by the fact that we didn't make drastic improvements with clinical outcomes. Policy is great, advocating is great, but until you are able to improve clinical outcomes for moms and ultimately for their families, you really haven't addressed the issue. So it's very real in the U.S. It's also very real in the U.K. and other areas of the world for Black and brown women, because it's not just African Americans, but it definitely is significantly a disparity for Black women.
So can you talk about what some of those disparities might look like, even in a kind of a first world setting? Because again, I think it's easy for our imaginations to think about, places with less resources, with just kind of governments that are not really there to even try to help people, so to speak. But I mean, when you talk about the UK and the United States, that still just seems very difficult to imagine. So can you help us understand a little more about what some of that could actually look like?
Right. And one really straightforward example, if we think about it, is obesity and our overall health. What I'm learning too on our journey is how you go into pregnancy makes a big difference. Also, women are getting pregnant later in life than they were. So there are more and more women getting pregnant, having their first child in their 30s and 40s. And we're seeing that globally, but definitely in the US. But also there is a huge focus on other aspects that are not clinical, but impact the clinical. And it has to do with the culture of the organizations and the trust between the patient and the provider, and not feeling heard and not really having the response to challenges or concerns in your body, that response being met with a specific clinical solution, but kind of assuming, okay, you can handle a little extra pain. So there is a combination of issues. There's also a huge focus on, biomarkers and understanding, are there some aspects genetically that drive outcomes within certain demographics and others. So it's not one specific thing, to be honest. It's the combination of, of course, what you have access to make good, healthy decisions, from healthy eating to how you take care of your body, to engaging as a partner in your care with your physician, of course, feeling heard, having access to great care. In the U.S., a good majority of people go back to work after 2 weeks of delivery. Yes.
2 weeks?
2 weeks, exactly. I didn't have to do that. But, that's not a problem in the UK because they take care of maternal leave and paternal leave. So there are a lot of dynamics that we see in the US that don't position us well to take care of the mom while she takes care of the baby. These are things that I listed that, for the most part, the physician can't solve independently. And there's an assumption that the physician or the hospital is the entity to solve this problem. But this is a public health crisis. So it requires a public health view on how to solve the issue using technology, using some innovation for sure.
Well, I feel like we could do like a 46-part series on this to kind of dive into some of these issues because, even I'm learning as I'm listening here that there are problems that I think that go largely unseen.
They do. By
a very large amount of people.
Yes.
And I know those are kind of vague, subjective measurements there, but I think that it's astonishing to me that in this day and time, with the access that we do have to information and the connectedness that we have, that there are still so many things that we are unaware of.
Yeah. Yeah.
And I think that's what, you're beginning to highlight here is just that there's even a problem with awareness.
Right.
We haven't even gotten to solutions. It's sort of like, are you aware or did you know? I think the next natural question, though, that people ask is why does it matter?
Right.
In other words, if you're not being affected by those things.
Right. And in truth, just in the state of South Carolina, when I first came here for grad school at the Arnold School of Public Health, the first thing that I was able to do is to go and view that corridor of shame, the Highway 95, and to really study rural health. And when we think about rural health in the state of South Carolina, you have a lot of maternal deserts. You have health deserts, but you're having more maternal health deserts pop up across the country, definitely in the state of South Carolina. And what that means is you can be pregnant in Bamberg County and maybe Jasper County, these very rural communities, and you not have an OB within an hour. So, wow. And not wanting to call it one particular county over the other, but there are places across our state and across our country where you could have an accident. So case in point, when I was pregnant with Lauren 12 years ago, my husband and I, we were visiting, it was our first child, of course, excited. We're visiting family in Clarendon County, South Carolina. So,
which is not that far away.
Which is not that far away, right? So that's where my in-laws live. And we were traveling back home to where we live in the Midlands. And that's when I got this unbelievable pain in my belly. I mean, I literally pulled up in the driveway. And my husband, of course, rushed me to the hospital, did 2 ultrasounds, and her heart just stopped. But the first thing my mother-in-law said was, thank God she made it back to Richland County. So that was that thought, that statement, I can't shake that. I remember that so well. And I'm so passionate about bringing light to something that people deal with all the time. And the fact that my mother-in-law said, thank God you made it out of a rural area of South Carolina and back to Richland County, where you have close access to really high quality care. Because again, my blood pressure was 200/100. I could have had a stroke at 29 years old. So they saved my life, right? So it's a reality that people make life and death decisions all the time. In rural communities, you decide, I can work through that pain, or that's not an issue, because you may have to decide to drive an hour, right, to an area that can really care for you. So, and those are big, complex problems, right? And Sure. We're finding our piece of how to address it, both with, of course, our digital platform, but also through our goals of impact, of reinvesting and supporting the public health strategies and markets where we're serving. So we have vision of grander impact for sure. Because I just like that's what you should do if you're a social impact business.
Yeah. Well, I appreciate that background, and there's, like I said, there's so much there, and I'm sort of only half kidding about a 46-part series, because I mean I think a lot of it is about people just are unaware. You know,
Yes.
that all this information is out there floating around, and unless people think that they have a direct need to know, they're not going to find out.
Right.
But again, back to your point about this affects so many people, a huge part of the population that, again, mainly goes unseen and unheard from. That's very interesting. Well, take us to where you are now, to where Health Evolve is now. You started this company some time back, and just take us to where you are now in this journey to trying to not just raise awareness, but to do something about these issues.
Right. Well, it's been exciting. It's been, in some ways, a bit of a roller coaster, but I think that's just the world. I mean, I was used to the busyness
Probably
of
means you're doing it
hospitals. Right. Well, that's good when you're busy, right?
Yeah.
Okay, that's good news. That's good news. I would say we're in a good place.
Okay.
I think the biggest thing as an entrepreneur is to cut through the noise and to hold tight on what solution you want to solve, because there's so many different ways to address the problem that we talked about. There really are. And there are people that are brilliant, that have raised and are VC backed, that are solving a part of the problem from a different vantage point, right? Or different angle. And all of that's good because the problem's big enough for us to all be hands on deck with this. So for me, we're right now in the middle of building and, of course, finalizing out the actual platform. We've had a lot of product validation, which is great, talking with hospital leaders, pharmaceutical leaders, patients, right, women, having conversations with the people that would put their hands on the tool and use it, be users of it, over the past several months. So we are building with excitement and with a deadline.
Well, and I know there's competition out there, and I don't want you to give away trade secrets or anything, of course, but can you share a little bit about what you are building?
Yes, absolutely. So we're building a platform called Lauren, and it's a patient navigator for women that are at risk or have hypertension, that also need to screen for postpartum depression, anxiety, and manage type 2 diabetes. So we're looking at these kind of a multi-aspect of chronic care needs for pregnant women, but also going beyond that. And in essence, what we're building is a patient-driven engagement tool. On one side, there's a user application that the woman can, interact with on their phone. And then on the other side, there's a back-end clinical SaaS platform. What really makes us stand out, I would say, are two very unique things that I'm not ashamed of sharing and shouting, because we have our own unique formula of doing it. One, our team of biobehavioral researchers we've developed our own health culture index that measures equity. So this is built into the tool. So we're able to stratify a recommended care plan using AI, but also looking at how it links up with health equity. So we're looking at the care a patient needs based on their health equity gaps. And that is unique. Right now, hospitals are trying to figure out how to do that because typically the data doesn't talk very well. We're still struggling to even collect social determinants of health, which is a baseline recommendation. I think that was first put out by the Institute of Medicine 20 years ago. And we're still trying to figure out how to consistently standardize the collection of social determinants data. So we built our own tool. With great researchers, great advisors, even from the University of South Carolina, that have helped pull that together. So to be able to look at health equity and risk is very, very unique. The other thing that's really unique about what we're building is one of those moments where I woke up at 4 a.m. and said, I've got it. Is where on the patient side, I kept thinking, what will make a very tired postpartum woman pick up a phone and engage when they may be sleep deprived and, all of these matters. And I realized that the one thing that women would probably need is a village. And this is a conversation we talk a lot about in my circles, and that's come up over the past decade, I will say, of raising kids, is the need for support, for help. And we are, as a part of our user interaction for the patient, we're creating a way for them to build their own digital health village. So that's the point where they can connect their insights with their physician, right? So we want that EHR integration. They're able to also pull in a loved one, whether they're in the state, across the country, another part of the world, to see what's happening within their body, especially after they delivered. And then they're able to connect with enterprise digital partners, whether it's a referral, a platform, or a therapy platform. So we're creating this digital village or ecosystem that's centered around the patient. The patient is the center of the universe with the tool versus the other way around, if that makes sense, where they're just a part of the health ecosystem. No, we're creating that ecosystem for the patient. So that's our design model. That's our approach, to do it that way. That way we can play in multiple sandboxes. We can work directly with the hospitals and payers. We can also work with major global employers that want to get into the space of employer-based health benefits and have a solution for their female employees like Lauren. So we were very intentional about that design, as well as what value we build into it that will help meet our impact goals of closing the health equity gap. So unique and exciting, and we're lining up pilot partners now and getting ready to submit our first major NIH grant within the next 60 days. So it's exciting.
Could you talk a little bit about what, because, there may be someone out here listening that could be one of those partners. What does a partner for this look like? I mean, who are you looking for in terms of partners to find to interact with this tool that you've made?
Right. Well, one exciting opportunity in terms of a partnership would be I would say a national virtual platform or telemedicine on a national scale, because there's some patients and there's some employers that may want their health consumers to be able to plug into the tool, manage their care, but also connect with direct help that's not necessarily their existing primary care physician, if that makes sense. So it needs to be kind of an all-in-one opportunity. In order for us to do that, it's important that we partner with a large digital health platform that provides behavioral health support, mental health therapists, primary care, virtual OBGYN support, so that literally from your pocket, you have access to everything. You can manage your own care goals with our AI. You can, of course, take our health risk assessments, know your category of risk, but also based on that and your health equity gaps, you can respond to a recommendation of engaging with a therapy platform and building out your digital village. So if you're in the business of providing direct care to patients in a digital platform, you're a great partner for us to talk with.
Also, this is sort of a random question, but what role, when I'm thinking about the patients you're describing, let's say someone that has hypertension that was just brought on by pregnancy, do wearables play a role? Because to your point, if someone's far away, like literally 40 miles, 50 miles, 60 miles from a healthcare provider, but they need to monitor their blood pressure.
Yes.
How do they do that in a way that can, is that where wearables come in?
Yes. So, and that's one of the partners that we're talking with now. I won't give too much away, but there's one in particular partner that is looking at vascular biometric data. Or vascular biomarkers. So we're getting blood pressure, central blood pressure data marks for the patients in real time. So at this time, we're not developing our own wearable device. We're having conversations with, again, two potential wearable device companies and companies that have an FDA-cleared device that we can partner with, so that there's also consistency with capturing the data, right? Because we know that depending on where you go to even get your blood pressure, it could be different than going to a pharmacy or going to your physician or wearing a certain calibrated cuff that's not over 2 years old or so, so there could be some variability with it. So, but it does play a huge part. And I will say one part of our tool is for those that do have a Bluetooth enabled device that captures that data already, they'll be able to integrate with the application as well. So we want to make it as easy to use as possible, where they're not manually entering,
Sure.
their blood pressure based on, the risk one they have or an Omron cuff at home, but they're able to connect automatically. So more of that functionality will definitely be revealed and released over time with us. Maybe one day we have our own wearable device. That's not out of the cards for us. In fact, I already have some thoughts on what that would look like if we decide to go that route. But that's important, especially if you think about these rural communities, and to be honest, in general. But here's the thing: we don't want to just serve the worried well. Right? People that have everything. I mean, I have an Apple Watch on right now. So there's the rings, there's all types of gadgets and toys that people can use to get a lot of information on their health. So obviously there'll be people interested that are the worried well, but we want to make sure people that just need to understand what's going on in their bodies have access to these tools, just like the worried well. That's important for us.
Yeah, that's an interesting term, the worried well, because, it's kind of like people talk about the rich get richer, in other words, people who are interested in their health probably are healthier.
Yes, you're right.
And people that want to track those things and will worry about it, if you will, are probably more predisposed, I would guess, to take action.
Yes,
where
right.
action, and I think your whole point is that there's a very, very large group of people out there, not just in the world, or elsewhere, but right here at home, right here in our state, much less, across the country or in all these other imaginary places, that literally just don't know. And yet the tools and devices are out there, the access, we're probably, my guess is Jasper County, there's no hospital system. And I'll say this so you won't have to say it, but there's no hospital system in America that's going to go to Jasper County, South Carolina and say, hey, let's build a comprehensive clinic to serve the people of Jasper County. It's just not going to happen.
Yeah.
And there's probably, if South Carolina has 46 counties, there's probably at least a dozen other counties where no existing hospital system is ever going to break ground on a facility in those areas.
Yeah. And the truth is there's a cost to being able to do that and do it well. And it requires manpower. It requires having a clinical team in those spaces. And we all know we have a shortage, right? So of providers. And I left the space of recruitment and growing medical groups. So believe me, there is a shortage. So even in the metropolitan areas, we're fighting over the best and brightest brand new docs to get to our markets. So a lot of times our rural communities really struggle to attract and draw in clinical support. So it's not just even the brick and mortar, it's getting the people, there to do it that and recognize you may not have Publix down the street, so those, and they have families, so basic public health challenges. But, there are systems like, of course, Medical University of South Carolina that has an expansive telemedicine platform. And of course in the state, we're expanding broadband. I think at least 90% of residents in Richland County have smartphones. That number is fairly high as well for rural health, where that's their access point to the internet. So we have the bones in place. For us, we want to be an extension to those digital health platforms and a resource to those that have the smartphones, which again is the grand majority of South Carolinians have a smartphone, and that is their access to the internet regardless of where they live. So how can we play off of what we have today and create an infrastructure to capture insights outside of the clinic? Right. So there's definitely an opportunity here, but you've got to lay on a strong public health game plan on top of our infrastructural plans as well.
Right. Yeah, to be continued, I think, on that.
We can talk health econ 101 with this.
I know. I mean, really, it's like, we may be the first repeat guest.
Nice.
Just to help people understand these things, because again, I mean, they're right under a lot of our noses, but because we don't have a need to understand, if you will. And I hate to say it this way, but even an interest to understand. Health is something that's intensely personal. You're very, very interested in your own health. But I think in terms of thinking about, even economies, healthy people have to be able to participate. If you want to have an economy, you have to have healthy people.
I'm glad you said it and I didn't have to. It's basic. You're concerned about your neighbor. You think about that may be your future ICU nurse, right? That's taking care of you in your last days. I mean, so when you kind of think beyond your front door and realize, okay, my health is linked to the health of the community. Yeah. It really hits home. But most people don't think that way. I mean, we studied this, right? So we get it. But of course, those in the hospitals. But it's important to kind of help people have that macro view to understand how does it impact, and COVID helped us realize that. A silly example, Starbucks didn't open until 9:00. That doesn't help me going into the office, going into the hospital. I mean, we can't get workers, right? Because of a major global issue that is a genuine issue. So the priority is on your health, not going to work at Starbucks, right? But those basic things, the struggle to recruit in nurses in the hospitals during the pandemic, and supporting those that were there. So COVID, I think, helped to open people's eyes to how the world and how other people's lives impact just getting my basic needs met.
Right.
Yeah.
Yeah. I mean, I think, COVID is that kind of gift, if you will, that keeps on giving in terms of, I think, what we're learning. But I think you're right. I mean, it for the U.S., I think I can say this pretty safely, that we have to have a jolt that's that hard and that vigorous to kind of shake us out of this. It's a weird mix of apathy and comfort that we live in, as a society. And I know I'm making some big blanket statements, and we might get some email on this.
It'll go to you, right?
It'll go to me at john@idon'tcare.com. But it's this mix of apathy and comfort.
Yeah.
Is what I see, at least in the world that I sort of live in and kind of navigate in, is kind of understanding, like you said, thinking a little more broadly than, your own home, your own business, even your own kind of circle and network, is that there's a lot more going on out there. So let's talk a little more specifically. I know you and I had a conversation before this, as we do with all of our guests, to really get into background and just to be able just to have a great conversation. But you mentioned earlier about you're applying for an NIH grant, and I remember you told me that in our previous conversation, and I asked you, hey, is that a make or break financial thing for your company? And I'll admit that I was expecting you to say that it was. Bias, me just trying to jump ahead and guess. It's just part of the process. But you said something that surprised me. You said, you know what? It's not a make or break. I know you would love to have that happen.
Yes.
But you said it was not make or break. Why were you able to say that?
Right. And I said it quick, didn't I?
Well, I mean, literally without skipping a beat, you said it would stink, however. Right.
And I said nothing is make or break. And that might be a bold statement, and I may get some calls too after that. But for me, I think I stated that I didn't leap out here just on my own will, leaving a company role and in the corporate setting because I just knew on my own I could do this. I'm a woman of faith, and believe that this is something that is linked to my purpose. But I also got a strategy, even during my own personal prayer time of how to create what I really call rivers and streams with the business model. And to be honest, it's something that really mirrors my experience working in healthcare for a long time. Remember, I know the business of healthcare pretty well. Was not a CFO, but I
you're
worked
an
as an
insider.
operator.
I mean, you've been inside the machine for a long time.
Oh yeah, I helped grow the machine, right? So I understand that in an entity, in a business, because healthcare is a business, you can't put all your eggs in one basket in terms of a revenue model. You have to be comprehensive, right? So you can't list one health system that only invests in primary care only as their sole source, and entities that only invest in primary care with no anticipation that it's going to support or provide some type of downstream revenue benefit to something else you're working on, is you're probably losing money. So for me, the concept of, again, rivers and streams just came out of, meditation and prayer time. So I think of two rivers that I have. Of course, I have my tech side, which is Lauren. But we also have been building out an infrastructure for our consulting side, our health equity consulting. So we're having great conversations with partners to subcontract on governmental contracts with HHS and other health-based organizations that have a strong interest in figuring out health equity and measuring health equity, and we happen to build a tool to do that. So I actually have a full strategy session next week in Hilton Head. I'm going through this with a partner. So we're creating this health equity as the river, but there's streams that involve subcontractor opportunities, other governmental grants, also just positioning ourselves in the right rooms, right, where the conversations are happening with the players. So whether that's in DC, whether that's in California, I'll be in California at Google headquarters soon in the next few weeks. So that helps with positioning, because there's not just health systems, but there are a lot of global players that have an interest in addressing health equity.
So something you said about getting in the right rooms. I think there are a lot of people that will be listening to this that understand what you're saying, agree with what you're saying.
But how do you get in there?
But they're stuck on one word, how.
Right.
With a question mark.
Right.
How. How did you position yourself to give them some inside information and let them kind of look on your playbook? Like, how do you get in those rooms?
It's so funny. I've been asked this several times, and I take it for granted, to be honest. I didn't think much about it. The simple, immediate response is to lead with service. That's the first thing, lead with service. But that was ingrained in me. I mean, I come from a line of ministers and teachers and people that just are servant leaders. So I was trained in serving even at homeless shelters and elementary school. So I naturally think of how can I serve others. So for me, I realized that I have two networks. I have my hospital, medical group, career network of friends from volunteering, right, and in these professional associations from my early 20s so I have this network beyond even the state, beyond the region, just from serving. And then I have 11 years of advocating in the maternal health space, just serving, with no expectation of anything in return. So one of the things I realized that's happening for me is, because I've been pretty consistent just with showing up as Kim, there are some rooms that I'm coming up to where I can see the door from the outside, and I can make a call or ask someone, hey, can you recommend me for XYZ, or I'm interested in this. And then there are some rooms where I don't see a door, but it opens up because someone's inside already talking about me, because they heard, oh, hey, Kim is building this now. This is exciting. We're watching her on LinkedIn, or we're watching her do this. Let me give you access to the room. And so one of those rooms that I was curious about, because I saw the room, was South Carolina Research Authority, right, SCRA. And through some great relationships and through a lot of work, we were able to become a member company in August.
Great.
So super excited.
Congratulations.
Thank you. So, and then they have multiple rooms within that room, right, to get access to. Working with 3-Phase SC on our NIH grant, just great guys, great people. And then there are rooms that I didn't know there was a room. Someone opened the door from the inside and said, hey, you need to come into this. So to me, those are rooms like invitation-only events that are taking place across the country, that someone says, hey, I know you're working on health equity. Let me put you on the list to receive an invitation, right, to fly to California to talk about equity and to just be in the room where it's happening, so to speak. If you can't tell my favorite place, you can tell. I'm not trying to advertise them, but you can tell my favorite place. And that's just from someone watching and observing, and they make the offer and invite me in. So I'm seeing both of those, but to me, it's showing up with, good integrity, being excellent in what you do, but also having a brand, a personal brand of leading with service. I believe that helps you well. And you got to have business acumen and all those things. But to me, it comes down to the person in terms of your ability to navigate. But you're not the first person that's asked, how do you get these meetings and these calls? And I said, I haven't even really asked 99% of my network for anything at this point. And of course, we're a young company, but I haven't really tapped in. It's been maybe 4 outside of our advisors, our board, 4 meaningful conversations that have kind of spiraled into what I'm doing right now, even down to who's developing my software, all based on relationships.
Right.
Yeah.
Well, I mean, you said a lot there. I mean,
Yeah.
I hope people hear it's not magic.
Yeah, that's true.
And it's also, and this is sort of it's just a pet peeve of mine, where people love to talk about luck.
Oh no, I don't really.
And I'm
about
lucky, or I'm so lucky for this to have happened, and I'm going to try to lower my level of sarcasm on that, because toes are being stepped on as I continue to talk about that. But it's not that. It's not magic. This is work, like you said, that you were putting in this work before you had the experiences that led to Health Evolve.
Yes. Mm-hmm.
And I think that is something that there are so many companies, and a lot of female-led companies, if we want to really be specific, that's the case. And I think that we are still being told, if you will, within the entrepreneur community, that if you're not young and bright and you've got just this world-changing idea, like that's how it gets done. And there are some of those out there,
right.
Companies that become verbs,
Right.
if you will, like Uber,
Right.
Or Google. Those are verbs.
Right.
They're not just companies. That's something you do. There's those, and then there's everybody else, like
Right.
literally everybody else. And it is based on, all the experiences that you've had up to this point. Have led you to where you are, and that was a multi-year process.
Yes.
And I hope that people are connecting some of those dots that you're putting out there, is to say that if you're not in your 20s, it's okay.
Right.
If you're not in your 30s, it's okay.
Right.
If you're not in your 40s, it's okay.
Right.
You've got stuff that you've picked up along the way. And
Right.
a big part of it sounds like your success is, hey, I'm just going to collect these dots and I'm going to start connecting them. And it is about character and integrity.
Right.
And those are those planks that you're kind of laying down in the road early in your career.
Right. Right.
And you never know really where that's gonna take you. But I'm so glad that you didn't use the word luck, because it's just just never the case.
Even if you have, even if you're a person of faith like I am, and you have this idea, which is great, I do still believe that it's how you achieve success is based off of the actions you take and the actions you have taken that have positioned you well for success. You've got to, there's some work involved. There's a lot of sweat equity, right? Leading into this. And even in the moment today, let's say in 10 years, we're this global firm that's, even maybe have our own exit. What's next, right? I believe everything I do in this journey will help to position me for what my next even looks like down the line. So I recognize that it's good to be good to everybody. That's what Mom says.
Well, yes, you can't go wrong there. And despite that sometimes good doesn't come your way, to your point of understanding how you need to carry yourself. And well, Kim, I'm so glad that you were willing to sit down and to tell this story. I know there were parts of it that were very hard for you to experience and probably still are. But I love the way that you've taken that and you've helped to turn that into something that is about helping other people, like you said, just to kind of lead with service. And I think it's important that you brought out that service really is giving. It's not giving to get.
Right.
You hear a lot about that. It's not transactional.
Right.
Or if it is, it's just a one-way transaction.
Right.
It's all outbound. And I think that I would agree. I think that is a big part of your success. And we certainly hope you have more continued success. And I do hope that a lot of people, who are listening to this are learning something, even if they're hearing some of these statistics that you've been giving for the first time,
right?
That it makes them curious and a little bit interested. To that point, where can people find you online if they want to dig deeper into this or contact you? How can people find you?
Great question. So our company website is healthevolve.co. And me personally, I'm on most of the social media platforms. I play a lot on LinkedIn. So I'm Kim Smith, CEO on LinkedIn. I'd love to get connected with everyone, and also on Instagram and X now.
Yeah.
As
Twitter.
That's right. Yeah. Twitter X, Kim Smith, CEO.
Okay. Mm-hmm. So healthevolve.co is the website.
Yes.
And then LinkedIn, Kim Smith, just look you up there, as well as the other socials. Well, I hope that people do come out to find you.
Yeah.
Wish you all the best as you travel and get into some more of those rooms.
Yeah.
And I'm so glad that you're doing what you're doing.
Thank you.